Dr. Kevin Wong.
Thank you.
Good morning, Dr. Kevin Wong.
Good morning. Just want to check everybody can hear me.
Yes, we can.
Yeah, thank you. All right. Yeah, thank you. And I assume that you can see the slides that I share as well. Thank you for that. Yeah, good morning and selamat pagi. Thank you for inviting me to ICCED 2022. All right, so today, as introduced, we're going to talk about the digital pathology using artificial intelligence techniques. So this is one of the projects that we have been working on for the past 2 or 3 years. So before we start, let's take a look at what is digital pathology and how is that important in the current world. And of course, later on, we'll look at why artificial intelligence can be used. So digital pathology is all right, and I think that is the same for a lot of fields that require image processing. It's actually a process of digitizing the histopathological specimens, all right, using what we call the whole slide scanners, and then we can analyze the digital slides using some kind of computational approaches. So I'm pretty sure, what we want to do with digitization is we want to use some kind of computational approach to do it. So I'm not going to go through all the wording. I'm just trying to use these figures to do some, explanations about how digital pathologies has been evolved. So if you look at the top part, is those are the traditional pathologies. So what you do is if you go for a test, or go to hospitals or pathologist clinic, they will take some tissues, all right? And then what they do is they will do some staining, as you can see, and then the stain will be put on the glass. And traditionally, all right, the pathologists will have to use some kind of microscope and then try to examine them and then write report. And of course, in the olden days, the reports can be through phone, but now emails and so on. All right, and then sometimes they might have a team of consultants that will have to look at the stain before they can, give you some diagnosis. So how is that being changed now? Is as you can see, the first 2 steps is still quite the same. So you still get the tissue, you're still trying to do the stain. What have changed now is instead of going to microscope now, you have something called the whole slide scanner. And you use the whole slide scanner to scan the image, and then you will send to the first pathologist, right, to use some kind of computational image analysis tools. And then from there, using the internet, using the cloud, of course, it's a secure cloud because it's patient information. And then you can then discuss with some of the consultants before you come up with the diagnosis. So that is the change that we have seen in the pathology world. So to go a little bit more, so what is the stain that the most commonly used is what we call a H&E, all right? And they can see on that pictures there is a glass slides that they have, more or less with the tissue and then stain with it so to highlight some of the features. And then this is the whole slide scanners that you scan through. And then this is actually what we have known as the digital image called the whole slide image. In short, is WSI. So now we need to know, because we have to work with, what we call the WSI. So we need to know the features of it. What is that? So WSI, whole slide images, are actually high resolution images. So they basically can capture the entire glass slides. And it's quite big, all right? It is in terms of gigapixel images and can range from 100,000 by 100,000 pixels. And the good thing about this WSI format is they have multiple levels with different zoom levels, just like the microscope, right? If some of you have used a microscope, you know that you can zoom in and zoom out. So there are different levels that you can zoom as well for the WSI, even though it's digitized. And the level vary from 3 to 7 levels. And each of the zoom levels will provide different information. All right, just like, when you look into the microscope, if you want to know more about that area and you want to diagnose whether there's a blood vessel, whether the cancer cell is true or not, you will have to zoom in. So this gives you an illustration on the magnification. You can go from 1 times and all the way down to 40 times. And of course, this slide is to give you an example. So on the left-hand side of the screen, you can see that is the whole slide image that cover maybe the whole tissues. All right, so sometimes the pathologist will have to go down and zoom into a particular area. And then after that, on the right side, you see that there is a zoom features that you can then analyze the features. So those are the basic steps. So what can we do with the WSI? And of course, this one here is mapped to what the human pathology is normally done as well. We put into the computational term is, as you can see, right, the first classification is more like the segmentation. So first category is segmentations. Right, basically you need to highlight. The first one that is most interesting is what we call the region of interest. So sometimes, you want to find that, particular area, whether there is cancer cell, whether there is maybe an evolving of cancer cell, then you have to zoom into the region of interest. I'm pretty sure, all of us use Google Map, right? When you use Google Map and you want to go to a particular buildings and so on, you start to zoom in, all right? So it's the same concept. And of course, there's a lot of other things that I'm not going through all of them, right? Under the segmentation. After you have done the segmentation to find, some of the areas of interest that you want to examine, then obviously the next one is to do detection. So the detections can be, a simple classification, whether it's benign or tumor or something like that, all right? And that is going through the classifications steps as well. So these are the slides that generalize, most of the things that is done in the pathologies using the WSI. So I'm just quickly going through here. There's a lot of wordings here, but I just want to highlight the difference between the conventional pathologies and what is the advantage and disadvantage of using machines. So as you can see, the list of the things that in pathologies, sometimes the main challenge is because humans sometimes you will have to limit by the amount of visuals features that you can identify. All right, and of course, as you can see just now, there's you can go from 1 times to 40 times, and you realize that in terms of cognitive load is quite a challenging one for pathologies. And of course, pathologies come with experience. So the more experienced you are, you realize that you'll be more confident and higher chance of detecting more accurate diagnosis. And then you look at the machines, right? When you look at the machines, then you know that sometimes you will have to deal with noise, right? And the challenge for this one is high dimension, all right? Because the image is huge in terms of gigapixels, and you can zoom in and zoom out and so on, all right? So that is one of the challenges there, all right? So all this thing has contributed to the challenge that we have seen by using the WSI. So in the past 5 to 6 years, AI has been used as a tool to actually help in digital pathologies. So from just the last few slides, I have more or less explained the complexity of how the tissues is being prepared, all right? And of course, I'm pretty sure today, all right, there's a lot of disease, a lot of cancer that's evolving as well. So the number of new cases are ever increasing. So you realize that is some kind of like a cat and mouse chasing kind of situations, all right? So that's why machine learning, especially, are very useful to be used in digital pathology workflow. So like, for example, classification, segmentation, registrations that can contribute to the task that I have illustrated just now. But one of the key things we know, if we want to use AI into the digital pathology workflow, there are still many challenges that we have to take care before it can be translated to the actual clinical workflow. So you realize that in research, there's always like, 2 steps. The first step is, try to come up with new ideas in the research lab, prove and more or less try to prove that it works, the concept is working. And the next thing that is what you need to do is to actually translate into the actual workflow so that you can actually use it. So this is what we are looking at today. So before we look at that, I'll just give you an overview. The most commonly used on the machine learning for digital pathology is deep learning, and quite many papers have been published. And this slide just more or less generalize some of the work that have been done. So as you can see, in deep learning there will always be 2 steps. The first step is the training part, and the second one is testing. Means you actually use the train model to do the prediction. So in the training part, as you can see just now, you work with host-like images, and you do the same thing as what the human pathology is trying to do. You try to find the region of interest, and then you zoom it down. Okay, but in deep learning, you realize that you have to divide them into patches. So that's why, when you feed into the deep learning, they will become into the patches. And of course, this one is a simple classification problem. Is whether the patch is considered normal, or you realize that the patch has some tumor. And then you try to train the deep learning. all right? And of course, depending on how you arrange your deep learning, and you realize that, the last layer of the deep learning, you can actually generate some kind of probability. So in that case, when you put into the operations, so you do the same process. So given the whole slide image, then you start to generate the patches before you feed into the deep learning. And then after that, you can more or less do a heat map. A lot of paper has reported on how they generate the heat map. And using this heat map, you can look at the probability of the cancer cell across the whole slide image. So this is quite a common way of using it. But as I mentioned just now, we need to translate that into clinical practice, which is a clinical workflow. And then when we try to translate into a clinical workflow, then we realize that there are a few factors that we need to handle. So on the right hand side, you realize that the large dimension is one of the key things. So I'm not going to touch on that because there are many papers that have already solved that problem, more or less, right? But these two, they are still evolving. There are many papers trying to work in these two areas, and the main reason is because these two areas are very important when you actually want to translate into the actual workflow. So let's look at the left side, the limited labors. So let's say, for example, if you work in the hospital, all right? So you realize that in deep learning, you need a lot of data to be able to train them, all right? Such that the deep learning model could be good enough. But then unfortunately, you also realize that the information from the patients could be private, all right? And some hospital may not want to share the information. So you realize that in each individual hospital itself, right, unless you have a consortium that you can gather a few hospitals together. So limited labor data is one of the problem. So beside the available data, the second one that is very time consuming is to get the senior pathologists to actually label the data. Because in order to know whether it's cancer or non-cancer, you cannot get maybe undergraduates or even a junior pathologist to do it, because sometimes they may miss some of the the region of interest or some of the features. So that's why we need to utilize the time of the senior pathologist. But you realize that if you are a senior pathologist, you have a lot of work to do, because all the report will have to come to you before you have signed off the diagnosis. So that's why limited labors is always one of the problems when we want to use the deep learning successfully in the clinical domain. All right. Of course, in research, we can use any public domain and specific to the type of cancers and so on. So on this one here, I'm not going through all of them here. There's a few things that you can go down. You can do partially labors. You can do weekly labor, of course, a weekly supervised training. And there's something I want to highlight here is the one class data. So you realize that for pathology, sometimes what they are interested to do is only looking at the cancer cell. But you know that in order for you to train a good deep learning model, you don't just feed them with the cancer cell. But that is unfortunately the behavior of because of time limitations, right? They won't look at all of them. So in that case, we will have to utilize what we call the one class data or one class classifications technique to do that. So besides the limited labors, there's another one, what we call the high variations. So high variations is if you have different hospitals, right, and they have different settings, sometimes you realize that the variation will be there. So I'll talk more about that when I talk about the actual method on how to help handle some of these problems. So first of all, we look at the first problem of doing the region of interest detections. So over here, we have used the RCNN. All right, RCNN is one of the popular deep learning technique that can actually identify the region of interest. So we use that in the whole slide images, and we want to see, right, if we put into the clinical practice, how is that look like? So before we go into the detail on how we apply RCNN in the digital pathology of identifying the region of interest, so let's first look at what is actually RCNN. So this one here is a very simplified illustration. So let's look at the first step. If you input the image here, all right, and then the first step, what you need to do is from the image, you will normally extract the region, all right. So you go through this algorithm. The algorithm will more or less go through and scan through the image and try to identify the region, and then they do some kind of region proposal. All right, and then from there, all right, and then they will compute the features. Why do they want to compute the features? It's because by identifying the features, then they can more or less classify the regions on the image. So as you can see, a simple example here, you can classify, a person's, a horse, and something like that. And you can even go down further if you want to zoom in further. You can, in the human face, you can identify the region where it belongs to the head, right? Belong to the glasses and so on. So this is the idea of using the RCNN. It's what we call the region-based convolutional network. So I think just now I have more or less described why in the digital pathologies, the pathologists are interested in the region of interest. So I'm not going to go through that again. So the whole idea is to zoom into the region so that they can analyze the specific area. So I'll just use this to illustrate to you. So if this is a WSI that's given to an algorithm, they should be able to do the same thing as what a human should do, is to identify the region of interest, right? So this is the first step. So if we assume that, we run past an algorithm, this could be the ideal case. So you can see that the green box given you a bigger region, but the red circle are actually maybe in the center of the region. When you go to the center of the regions, normally they give you more features. They can help you to decide whether, whether it's benign or tumor. So as I mentioned again, right, the whole slide image is a huge image. So that's why region of interest is very important. So this test that we do, we collaborate with the hospital in Western Australia, is they come back to us and they say that they are interested to look at how the computational of the region of interest to identify what we call the Germany Center. In short, it's called GC. So why Germany Center is interesting for them is because Germany centers are organized, some kind of collections of activated lymphomicals and other immune cells, and that can actually, develop into some kind of immune simulations. So a lot of times, pathologists, by identifying the GC and then trying to, understand the features under the GC, then they can more or less diagnose whether something is cancer or non-cancer. Right? We'll look at later on in the next slide. I'll tell you what kind of cancer that they're looking at. But a lot of time to identify the GC, even for a lab practice, using the H&E stain itself is not good enough. So what they have to do is they have to go back to the lab, they have to wash away the sample, the tissues, and then stain it with another stain called the BCL6. And the BCL6 then can highlight the GC cell. So you realize that the workflow to identify the GC can be quite time consuming because, from the H&E, right, you try to identify something, but to confirm it, you need to go back and wash it and then stain it with the BCL6. And the worst thing there, then you have to register between the BCL and the H&E, all right? So what we're trying to do here is we're trying to use the RCNN to actually identify the region of interest. So just now I have more or less illustrated to you using the picture. I'm not going to go through more into detail. So RCNN has two steps. The first step is to identify the region, which is the region proposer. And then the second step is to identify the features and then classify the proposed region, all right? So this is more or less summarized here. So first, we have this WSI coming in. So in here, we try to work with the pathologists and say, in order for you to identify GC, which level of image do we use? So we have chosen level 3 for this purpose here, all right? And then the first step is region proposer. After the region proposer, they have identified the region, then they extract the features, and then they do the classification. So over here, the region proposer basically is trying to select all the region. But one of the things that I want to highlight here is the region proposer steps is important because you realize that, for you to identify the candidate, you have to be as confident as possible. So that is why, that region proposer is important. And normally this one here is done by some kind of greedy algorithm. Okay, I'm going to more or less skip this one. All right, there's a lot of details here, but if you're interested, let me know. I can give you the papers, and then we'll have all these technical details in there. So let's look at the experiments that we have and how is that being able to be used. So WSI patients from a public hospital in Western Australia are used in the study. So they give us 60 WSI for training, and then after that, we have to use the trained model to test on the 12. So there are 2 steps in these studies. So yeah, there's one thing I forgot to mention here. So obviously is to identify the GC. So what the pathologists are really interested is to actually know whether there is a normal and benign lymph nodes. So lymph nodes is, you realize that is more or less next to your arm, and to diagnose the lymph node cancer sometimes can be challenging. So that is one of the key things that they want us to look at. So we first have to build the RCNN, and we realized something just now when I show you, right? If you still remember that we have a square, right, to identify the region, and then we go all the way to the red one, which is the center of the features. So given the behavior of the human, we come up with 2 hypotheses. So we can come up with what we call the base case RCNN, and in that case, we use 244 by 244 patches, all right, to learn and predict. And then we also realized that human actually zoom all the way to the center of the GC to identify some important features. So we say that, okay, now can we also use RCNN to go all the way into the center, right, instead of just the square box? And that is what we call the center case RCNN. We more or less want to do some kind of experiment to see which direction we should go. So from the first experiment, right, we use some kind of RCNN build, and we realized that true enough, if we go like what the human has done using the center case, the IOU is actually higher. So in that case, we decided that now we should use the center case RCNN to build the region of interest to identify the GC such that the pathologist can then examine whether it's benign or non-benign lymph node. So a lot of time in deep learning, experiment is we have training data, we have testing data or validation data, but you realize that those kind of data sometimes you can optimize the model to give you the best. And the pathologists know about this. They come back to us and say, no, we're not going to give you all the data, so we give you 60 and 12, but we keep the 6. All right, so you come back with your model, we do a competition between your machine and our junior pathologist, which is a human. So they want to see how well human and the machine perform. So that is what we call the unseen data testing, and that one is done together with the hospital. So from this one here, this table here, you can see those 6 that has been kept away from us, right, which means that we cannot use it to optimize the models and so on. As you can see, the first slides, the human identify 44, which is their technicians identify 44. Our RCNN also identify 44. But interestingly, you realize even though they identify 44 and 44, but there are actually 4 of them which are different. Then we need the senior pathologist to confirm. So this table will give you illustrations on how many each of these has identified and what are the discrepancies. So to give you this example here, just one slide. This is the first slide, and this one is identified by human. All right, so the human will go through the WSI using their computer, and then now they find those 44 region of interest. And the next one is identified by our RCNN. All right, obviously, if you see this and this, you can't see the difference. It looks quite similar. But then when the senior pathologist put side by side, and you can see that on the left side, all right, the human actually meets the 4 of them, and the machines also meets 4 of them. All right, so then the senior pathologists have a good idea. All right, so this is the performance. So which means that human and machines both are not perfect in a sense. And this is again another slide of comparing these 2. All right, so obviously going through this exercise, we now know that we can actually adopt a theory called human in the loop. So which means that now the senior pathologist can actually mark them, and then now we go back and refine our model from there. Right, so this is human in the loop performance. So this experiment is still going on, because in order to work in the clinical sense, we need to more or less make sure that all of them are as good as possible. And of course, you realize that by doing this, the human pathologists learn as well. So human and machine actually work hands in hand to enhance their experience. All right, so which means that now we can release the load of a senior pathologist. I'm going to skip all this because I don't want to present like a research paper, because you more or less can look into that. So that is the first exercise we have with the Western Australia Hospital, and trying to put them into practice. All right, so that the human and the machines actually both learn from each other and then get more and refine from them. So that is the region of interest. The second one is we want to deal with the problem of limited labor data. So in here, we use the technique called transfer learning. Transfer learning is getting popular in the AI domain, right? And see how they can actually help to improve the classification. So before we do it again, I just want to quickly go through what is actually transfer learning. So transfer learning is like, from that pictures, right? If you know how to learn table tennis, so maybe if someone asks you to play tennis rather than table tennis, right? You have already know some skill. When you see the ball from which angles and so on, you need to put it back and so on. So you use some kind of soft domain knowledge or experience that you gain, and then you try to adjust to the target domain. All right. So that is the fundamental of transfer learning. So without giving you a lot of formulations, this is the background. What is transfer learning? So if you still remember why we want to use the WSI, is because the WSI is to generate the digital image, and of course, in order to generate the digital image, you have to go through the scanner. All right, and depending on the scanner itself, depending on some of the environmental conditions, you realize that sometimes when you prepare the slide or the WSI, it could be different. But of course, in image processing, there's a lot of other techniques that you can look at, like for example, grayscale conversions, color normalizations, color augmentations, and so on, to actually try to match the different sites differences as much as you can. All right. So the hypothesis here is, if we have limited data from different sites, right? If we only train the data from one side and now we build the model and we want to pass the model to another site, what can we do, all right, with that? So that's why the transfer learning is being considered, because we don't want them to retrain in the new site with a large amount of data. As I mentioned to you, in different sites, there's always these limitations of data. All right, so I have mentioned about the transfer learning, so I'm not going to just talk about this. I just want to illustrate this. So what is transfer learning here? Is, first of all, we use a pre-trained network. So the pre-trained network, if you realize, if you go online, you can find many pre-trained network, all right, like AlexNet, GoogleNet, and so on. They normally pre-train with large amount of images, all right? So there's an ImageNet that you can use to train a large amount of images. And then after that, all right, you will fine-tune with your, let's say, Hospital 1 data set, right? But after you fine-tune your Hospital 1 data set, now you're going to transfer to Hospital 2, which is a data set 2. But let's assume that in the Hospital 2, you only have the data that is what you are interested in, which is what we call a class 1 here. So class 2, you only have the data set from the Hospital 1. So this is what we call the one-class classifications. All right, because the target, which is the target site, only have the interested class, and they have no time to label a lot of data. So the question here is, how are we going to use this part here to fine-tune the layers such that we can do classifications? All right, and of course the accuracy, will be as accurate as possible. But to do the experiment, we also want to look at some other technique that pre-processing has been used. So what we look at is the data augmentations. Data augmentation is being used by image processing most of the time, like if you don't have a lot of data. So what you need to do is you do pre-processing, trying to change and vary the data. The whole idea is to come up with a variation of the data so that you can use it. And of course, the next one is to do histogram equalizations. So this is just to give you an idea of the data set that we use. I'm not going into details on this. If you're interested, again, I can give you the papers and there will be more detail in there. Again, this one is looking at lymphoma subtype classifications. So obviously, those are the data that you can gather from public domain or from Hospital One, all right? And now we have a second data set, which is now the Western Australia Hospital, all right, given us some data and say, look, this is the FL class that we are interested. We only have FL class labor. Can you do something of it? And again, all right, when you work with hospital, work with industry, they always want to keep the dry test to test whether your AI is really that good, all right? So first, we have to look at the histogram to understand the different sites. So if you look at the dataset 1 and dataset 2, you can see that the color histogram distributions is somehow different. So the assumption made here is we use a machine learning technique to learn from the first site and try to use from the second site. You realize that the accuracy will be affected. All right, so which means that we need to do something about it. So this one is looking at the blind test data. All right. So the first one is you train with site 1 and you predict site 2. So which means that, when you go to site 2, because they don't have enough data, you can't retrain them and just use it, and that is the accuracy. The second one is you try to combine with them, all right? Then you realize that the accuracy is quite high. I know that the accuracy there is a little bit too high. I was quite shocked as well, but the reason behind is because the blind test data they have is quite minimum, right? They keep quite minimum. And apparently a lot of them has been used in the training, all right? So it's quite similar features to the training. That's why the accuracy is definitely quite high. So this is one of the exercises that we're also trying to work with them to keep on refining the transfer learning. So this one here is to show you, there's something that I forgot to show you. So if you look into the augmented and histogram equalizations, all right, so if you are talking about just using one site data, the augmentation and histogram equalization doesn't really help much, but the histogram equalization actually help quite a bit, all right? But of course, this one you have to go through a few cycles of optimization, all right? Whereas the second one is you train them and you try to achieve the result. So this work is still going on, as I mentioned, all right, and trying to see whether the transfer learnings can be used. Again, I'm not going through due to the time constraint. I'm just going through to talk about, the last few slides. So those two have looked into how we deal with the region of interest and the limited labor data. And this one here is one of the ongoing experiment we have, and we have just finished one trial, right? And then we are still working with the hospital to come up with a lot of blind test data, and we will be submitting that into a journal. And this one here is we are using a GAN network, which is a general adversary network. What it does here is, we use some kind of noise data coming in, generate some kind of synthetic images, all right, and then we use a discriminator to actually try to generate more data, all right. So with this one here is we try to fine tune the synthetic data to use as much synthetic data, which is hopefully as close to the real data, to train the deep learning as well as much as possible. So that work is ongoing. So I just want to highlight here, there's some other work that we're doing. We recently just submitted a conference paper on federated learning. So what is federated learning is in the deep learning model, you realize that in order for you to train the model, you need to get the data from all the hospitals coming to the same location and train the model. So federated learning is you can actually do distributed learning. So let's say, for example, Hospital 1 and Hospital 2, they don't want to share the data with each other. So which means now you just need to have a server, right, feeding into the model. Then each of the hospital can use their own data to refine the same model at the server. All right. So this is the federated learning. So again, this one we have just more or less published the paper. And of course, the other thing that we are working on is the virtual reality and the multi-user. So which means that now we want the human in the loop to work, which means that the machine and human work hand in hand. But we realized that over the past 2.5 years is a bit of challenge because of COVID. So a lot of pathologists have to work remotely, and now we look into how to bring them into the virtual world. So we have the AI coming into the virtual world, we have the real human pathologists coming into the virtual world, and then how they can work together to improve the prediction. So as you can see, right, to actually work into the workflow of the digital pathologies, we realize there is a few issues here that we are continuously, trying to handle the problem. So anybody here, if you are really interested, I'm happy for you to come and have a chat with me, and we can work together in the clinical workflow domain on handling how to deal with this uncertain data, noisy data sometimes, because of the labeling and so on, and of course overlapping data, missing data, imbalanced data, and so on. And of course the last one that we are really working on in the past 1.5 years is to how to deal with the privacy and security of the data. And that's why you can see that why we are looking into federated learning, all right? Because we realize that a lot of hospitals, they don't really want to share the images because of we can understand of the privacy issues of the patients. So lastly, this one here is from we working with the digital pathologists and the hospital. We realize that the main reason why AI project fail is all these reasons here, and I'm pretty sure some of you who have used machine learning or AI in some of the real world applications, you realize that one of the key things we have to handle is the data. As you can see just now, right? The data given to you from one hospital, they might have a bias to the condition of the first hospital. But when you move to the second hospital site, you need to do some adjustment, or whether you do a histogram equalization or some other pre-processing, or you have to use transfer learning and see how you can enhance your model. And of course, the data quality is one of the important issues why the project failed, right? And of course, the first two is very important. What we understand today is that it's very difficult to build a deep learning model that can predict all type of cancer in one. All right, so like for example, we work a lot with the pathologists on identifying the lymphoma cancer. So the model will be concentrating on lymphoma cancer. And lymphoma cancer, according to them, is one of the difficult problems they're looking at. And in fact, we just started a project with them is to look at the prostate cancer. So prostate cancer, again, we need to more or less collect the data and so on. So that is one of the things here we look at. And of course, the fourth point here is lack of reproducibility. So a lot of time you realize that the deep learning has been used, but it's very difficult for the practitioners or the human to actually reproduce the results. All right. And of course, the last few, which is very important, ethical AI, because we need to protect the privacies and the secure data for the patients. And of course, when you predict something, at this moment of time in pathology, the human is still the final decision. We cannot fully rely on the machine to say that whether you have cancer or non-cancer. And the next one, which I'm pretty sure those people working in AI will realize, is explainable AI is very important, and it's getting very important in medical as well. There's a lot of time in deep learning, all right, they can say that this area, the probability of having the cancer cell there is, let's say, 95%. And then when a human pathologist come back and ask, how do you know it, right? It's very difficult to come up with a very distinct answers for that one. All right, so these are some of the things and some of the problems that we are still continuously trying to work through and trying to explore ways to improve it. So last but not least, I have to mention that this is not only my own work, this is actually a team effort. The first person, Dr. Jeremy Perry, is actually a senior consultant. He also runs a company, so he's actually provided a lot of expert knowledge in this, and that is how I learned about digital pathologies as well. And of course, Chris Humans, working in the Fiona Stanley Hospital, he's the one that come back with a lot of blind tests and come back and criticize that the machines is good or not good. And we have a research fellow on a PR, and Upika, PhD student who is finalizing the thesis now. With that one, thank you for your attention, and I think I finished my presentations today. Thank you.